biopsy or you want to do the core needle biopsy?
Core needle biopsy we can do, sir, under image guided, ultrasound guidance.
So when you're doing a core needle biopsy for the parotid, what precaution has to be taken?
Facial nerve shouldn't be injured, sir.
So how will you do that? How will you preserve the facial nerve?
We'll go parallel to the facial nerve, sir.
Good. Yeah.
Another thing when you are doing this, you suspect the cutaneous involvement. But here, already the skin is much involved. Anyhow, you
Yes.
are going to not spare the skin.
Yes, sir.
So you are justified in doing a core needle biopsy.
Core biopsy. Yes, sir.
The core needle biopsy just gives you an idea that it's a malignant tumor is there.
Yes, sir.
And there are few mesothelial cells are there and few fibrous cells are there. Atypical cells are there. Then what next you are going to do?
MRI can be done, sir.
Okay. MRI for what?
In order to look for the extent of the tumor, sir.
Okay.
Whether deep lobe involvement is there or not.
Right.
Is there
Okay, so
any
you are-
clinical evidence for a deep lobe involvement?
No, sir. She did not have any deviation of tonsillar pillars or volvulus or nothing, sir.
Okay, so the deep lobe is not involved. It is only from the superficial lobe. Biopsies, atypical malignant cells are there.
Okay, sir.
What next?
Minimum biopsy for any parotid swelling is superficial parotidectomy, sir. So we can do a superficial parotidectomy and intraoperative frozen section can be done, sir.
But do you think in this patient, you will be only doing the superficial parotidectomy in this
Sir,
patient
since
where
highly
almost
malignant.
whole of the skin is involved, getting involved here? So if you are going to excise that, you're almost half of the face skin will go in that.
Yes, sir.
So you would like to go for that superficial parotidectomy in this patient?
No, sir. Since it's a malignant, we can proceed with the total. Sir,
Sir, sorry, sir. Ajay Khanna, sir, he has got the CT pictures, sir. It has got an extensive involvement. Kindly show the pictures, get the expert opinion. Then, so you got the
Okay.
CT pictures.
Yeah, you
Now,
can show the CT picture. Yeah.
how far it has extended. It has gone into the external auditory canal, base of skull. There's mild involvement. It's a huge one, sir.
Mhm. Yeah, that is why, we're saying superficial parotidectomy, not for this case.
Why you said that one? Now you are correct, no? But you should say, sir, I got the CT pictures. Kindly give your opinion. You ask.
sorry, sir. I'll correct it, sir.
Yeah.
So where the extensive involvement is there.
How do you say that is a parotid predicate plates are involved or base of the skull is involved?
Sir, there will be widening of the foramina, sir. Skull base, the foramen, ovale, and spinosum, everything will be widened if it is involved.
So what is happened in this case?
I couldn't appreciate properly, sir. Kindly teach me, sir.
No, that is
It was almost closing the external auditory canal, sir.
See, there are one or two things, Dr. Kavya,
Yes, sir.
which is important here. Skull-based infiltration is more important from the management angle or only the external auditory, the canal here.
Skull base involvement is important, sir.
Skull-base. So what is the better investigation for this now?
MRI will be better, sir.
So you have got an infratemporal fossa infiltration or deep lobe tumors or going into say facial nerve interface of between the superficial and deep lobe, that facial nerve plus skull base. They're all where you require basically MRI. So keeping that in mind, so the MRI is a better investigation. Okay.
Yes,
So
sir.
I don't know whether we can make out.
no, we are not able to make out anything.
Only you have to discuss. You would have done discussion with the radiologist. You should be able to tell us. That's all.
What is the report?
It
Sir,
was
report,
discussed with the tumor board, sir. The surgical oncologist said it is extensive involvement involving the external arteries, going to the parapharyngeal space. So it is highly inoperable considering the age. That was what the report was given.
Definitely, it is in a state of even looking at the skin, it is not in a state of operable conditions. Yeah.
Yes, sir. Where we are
The
transferring.
pterygoid plate is a T4A or T4B.
Which one, sir? Pterygoid plate T4B, sir.
External artery matters.
T4A, sir.
So T4A is operable.
Yes, sir.
Even if they are going for the T4B, if you are sure that then it becomes inoperable. But here there is a extensive involvement of the skin, you will lose quite a lot of skin. So it is not the primary advice to say, just like what you said, superficial parotidectomy.
Okay,
You
sir.
can't say in this case.
Okay, sir.
See, Dr. Kavya, you have read the book and you are told that minimal biopsy done is it is not that way. It all depends upon your case. Such
Okay.
a large one. So even there is a edge is ulcerated. So these are the options you have got. Core needle is an excellent option, especially such a large one. You think you will go straight away for operating on this patient without a proper histological diagnosis?
No,
That should not happen. It should not happen. It's
Yes.
a large one. So you have to keep that in mind first.
Okay.
Etc. Then, of course, as you mentioned, that MRI and tumor board discussion and all that thing. Just to little deviation. If you suspect soft tissue sarcoma, what do you expect in a core needle biopsy? Suppose this is a soft tissue sarcoma arising in the parotid region, for example, yes,
Okay.
angiosarcoma, whatever it is. What do you expect? You should mention, of course, ultrasound guided, whatever that core needle, but what do you expect pathologist to report?
Spindle, sir.
No, that is the type, sir, but in terms of important issues, grade, you heard of that? Type of the cells,
Yes, sir.
like what? There are various types have been already mentioned, is it not?
Yes,
So,
sir.
what about grade of the tumor? Mitosis.
Okay.
G1, G2.
So all the possible information you should be able to get. You understand?
Yes, sir.
Mitosis. So many information you can get in a soft tissue sarcoma. According, we'll also stage it slowly. Yes. Yes, sir.
So what do we plan for this, sir? Because the oncologist took over. They said we are going for debulking and try to do a chemo and we'll wait. But the prognosis is great. Is it correct, sir? Because we are transferred the case to oncology, sir.
Yes, sir,
Clinical
definitely.
interest.
Radiotherapy has no role, sir.
Uh,
Otherwise, you can have subject the patient for radiotherapy. But in this case, radiotherapy has no role. So only option is only a debulking. But this patient has no pain, no other symptoms. But if you are going for a debulking itself, it will be complicated and you will not be able to save the facial nerve. Getting into more problem will be there.
Okay, sir.
but they have taken over. They said we will do and we'll let you know. That's what, sir.
No, I think probably, if this is my patient, then I will take it as a case of a sarcoma of the parotid.
Yes, sir.
Okay.
I will give this patient a neoadjuvant chemotherapy and also the radiation also,
Okay, sir.
and then followed by the surgery, not as the debulking as the first choice in this patient. At least the chemotherapy in this patient
Chemo.
has to be given in this patient here. At least the chemotherapy has to be given in this patient. You can give a broad spectrum type of the chemotherapy. You are not able to make a choice between a carcinoma and a sarcoma. So you can like cyclophosphamide and all those types, some type of the chemotherapy has to be given. And then only you should go for put your knife there. Because if you're going to put the knife there, you will be really definitely the soup will be there. The patient will come back to you within a week with all the nodules all over the face.
Okay, sir.
Yeah. So at least in this patient, even if you are not able to make a firm diagnosis that whether it is a sarcoma or a carcinoma, we know it is malignancy. Okay. There's no doubt about that.
Yes, sir.
Okay. It cannot be a benign one. It is a malignancy.
Yes,
It
sir.
may be a mixture of the carcinosarcoma, or it may be sarcoma only or the carcinoma only. there are so many types of carcinomas and sarcomas which can occur in the parotid. Jay.
Yes, sir.
So based on that, we can give the patient the broad spectrum type of the chemotherapy, see if there is any response is there. And
Okay.
then if needed, then you may think of doing some type of the palliative surgery in this patient. You are
Okay, sir.
probably not going to cure this patient. That is pretty sure.
Yes, sir.
You're only just going to do the palliation for that, because this is ultimately, within 1 month, this will all fungate. And there
Yes.
will be bleeding from every place. There will be maggots will be there, and all those things will be there in this patient.
Yes, sir.
Okay.
Yes, sir.
In this case, can they bring in sarcomas, one of the diagnoses, for the peripheral postgraduates? Carcinoma, next the sarcoma.
Sir, they should bring sarcoma, definitely, sir. That whatever the parotid, definitely adenoid cystic carcinoma, one of the very rapidly growing tumors. But definitely, sir, sarcomas. You are talking about what carcinoma, sir?
When I say about adenoid cystic carcinoma, sir.
Yes, definitely. It is one of the very rapidly growing tumors, elderly people. So they can, sir. And even sarcoma, sir. Sarcoma of the parotid.
What is the
Yes.
common tumor in the childhood?
Hemangioma, sir.
No, that is always the parotid has a lot of vascular part, and angiosarcoma is a very, very common type.
Yes,
So
sir.
now better time if you want to use the chemo radiation, because that is not is being combined together. Both.
Okay, sir.
The first line only option is only chemo radiation. Then only you have to go for surgery. You should not use the surgery as a first option, debulking as a first option. It is better to go for that. And the second line is an advanced targeted therapy and immunotherapy. There are
Yes.
some hormonal targeted therapies also tried, leuprolide, some like they are giving for a hormonal advanced cases, stage 4B cases, they are trying for that. So that can be given. First, probably diagnosis with chemotherapy, chemo radiation, followed by debulking if it is improving. And a case like this with no other advanced symptoms, like then we'll not unnecessarily meddle with the case and end up in a flaring up of the disease and getting into a lot of complication.
Okay, sir. Thank you, sir.
For the benefit of the postgraduates, if we are removing this tumor in total, what are the various reconstruction options available? Please enlighten, sir. We are removing the tumor. The pinna can it be removed, sir?
Now, the concept of if you are not intending for a curative therapy, palliation, doing a wide extensive area and thinking of a flap is very, very remote, sir.
Very remote, sir.
If you think that is you are going to give a curative, definitely you can go. But when you are going for a stage T4B tumor,
Yes, sir.
it's not advisable to go for that.
So conservative is the best, sir.
At this stage.
This stage.
So you said the pain is there, ma? The pain is due to what?
Neural infiltration, sir.
You are
Very-
expecting which carcinoma you are expecting then?
Adenoid cystic carcinoma, sir.
Do you think that this will be an adenoid cystic carcinoma?
Sir, it's a rapidly progressing malignancy.
Which nerve will be in what? Adenoid cystic carcinoma?
Facial nerve infiltration is common, sir.
Facial nerve is a motor nerve, ma?
Yes, sir. Her pain will be due to sensory
What is the
auricular.
sensory component of the patient?
Sir,
Which nerve, ma?
What?
nervous intermediate.
No, not facial nerve. Which other nerve? Sensory nerve.
Trigeminal nerves.
There are other nerves are going through that, no? Nearby there's lot of nerves. So this, can it be if it is a mucoepidermoid carcinoma, what type of mucoepidermoid you are expecting?
High grade, sir.
What do you mean by high grade?
Epidermoid type cells will be present, sir. More.
This is more in favor of a epidermoid type because ulcerative lesion is coming. It's
Yes,
not
sir.
you never said it is a soft consistency. It's always mucinous part will be always a hard,
Okay.
soft consistency. So it could
Yes.
be a high grade mucoepidermoid carcinoma.
Okay, sir.
That will have some response to radiotherapy.
Okay, sir.
The epidermoid feature is more predominantly that will have the prevalence, response to radiotherapy. So This case definitely you can, but for the chemoradiation can be definitely tried for this.
Okay, sir.
Now, is the biopsy done in this patient or not?
FNAC was done, sir. In that, it was adenoid cystic, sir. After that, no other biopsy was done, sir.
Which is
The
more
needle,
aggressive.
needle biopsy has not been done.
No, sir.
Mhm.
Which is more aggressive?
Adenoid cystic carcinoma is aggressive, sir.
Yes. So which is an investigation of choice to adenoid cystic carcinoma?
FNAC, sir.
MRI.
Neurological predilection.
Neurologic. Okay, sir. Okay, sir. MRI.
So facial nerve is involved means it comes to what T?
T4A, sir.
T4A. So facial nerve involvement is only T4A. Only when
Yes.
it is go to the pterygoid place and you are going to make it as a. What is
T4B.
extra parenchymal involvement?
Extra parenchymal involvement surrounding, it's infiltrating into surrounding structures like masseter,
Is it a microscopic or macroscopic?
macroscopics.
The microscopic involvement, even if you are postoperatively, it comes as that is not comes under the extra parenchymal involvement. Even you are clinically or macroscopically, you can make it out that you are going to make the picture.
Yes, sir.
What are the various types of facial nerve involvement? Or like if you are doing a surgery in this patient, what
Okay,
are the
sir.
various types of facial nerve damage which you can carry out?
Complete transactions, sir, can happen.
Yes. Yes. What else?
Neuropraxia, sir, due to handling.
Okay. Right.
Or branches, any damage to facial nerve branches while removing the tumor can occur.
Okay.
Do you know the classification for facial nerve?
House Brackman grading will use, sir.
Okay.
It's a
No, but
clinical study.
broadly, how do you classify the nerve involvement? Nerve injury?
Sir, my House
Broadly,
Brackman scoring, sir, and 6
no,
grades will
that
be
is for
there.
the facial nerve. No?
Okay, sir.
I'm asking for any nerve which is there. So how do you classify the nerve injury?
Neuropraxia,
Yes.
axonatomosis, and neuronatomosis.
Okay. So what is the difference between these three?
Neuropraxia is the mildest one, sir. Weakness will be present and
No,
Endonurium
in terms of anatomy, what is the difference?
endonurium will be involved, sir.
So will there be an anatomical damage there?
No, sir.
And in axontomosis?
Axon damage will be there, sir. Epineural.
What will happen to the perineurium?
It will be intact, sir.
That one. And in case of neurotomosis,
Complete transactions. Perineurium also
it
will
will
not
be
be
complete or it can be partial. You know?
Yes, sir.
Both it can be there, partial
sir.
or the complete one.
Okay, sir.
So if you if out of all the facial nerve branches, if you have to save one branch, which one you like to save?
Zygomatic branch, sir.
Why?
Because it supplies orbicularis oculi muscle, sir.
Mhm.
If that is damaged, patient cannot close his eyes, which can lead to exposure keratitis, sir.
Okay. So what is the treatment for the exposure keratitis?
Artificial tears we can give, sir, and surgically lateral tarsorrhaphy can be done, sir.
Yes. Any dynamic procedures which can be done?
Facial sling procedure using zygomaticus to temporal muscle.
And
What is the simplest advice you will give? Sorry, Dr. Ramya here.
yeah, please, yeah.
Good evening, ma'am.
Before you plan all these procedures, what is the simple advice you will give for anybody with a, what is that phenomenon called?
Bell's phenomenon.
Yeah, so what advice would you give this patient day to day before you plan for all this facial sling and all those stuff?
He should be covering the eyes, not letting it open, and artificial tears we advise the patient.
Covering the eyes, especially when he's sleeping.
Sleeping, yes, ma'am.
Okay, daytime they may somehow protect their eyes.
Okay, ma'am.
Sleeping, it is involuntary. The corneal exposure will be there even during daytime, but definitely they should cover their eyes by either wearing specs or eye shade or whatever it is. Okay, then that is drops, that is eye drops is correct. Then the rest of it, as Sir said. Okay, yeah.
Suppose during the surgery, you see the facial nerve is involved.
Yes, sir.
What you will do?
We'll sacrifice the nerve, sir.
Suppose you are able to remove the maximum part, only the microscopically you are leaving it again.
Sorry, sir, I couldn't get the question.
No, like suppose your nerve, you are able to remove the entire mass, whatever you are seeing macroscopically.
Okay, sir.
Still feel there is some microscopic you would have left over. So will you sacrifice the facial nerve?
Microscopic involvement. Yes, sir.
No.
Sorry, sir.
The facial nerve and the recurrent nerves, even if there is a small microscopic portion, it's not, we are not thinking of a R0 at that level clearance. Even
Okay,
if there is a small portion, if you see, that
Okay,
is,
sir.
your option to sacrifice the nerve comes very, very, when it is totally encompassed, totally it is not able to be separated, only you can go for that.
Okay, sir.
Suppose you do the cable resection and you resect a small portion, then what you will do on the table?
We can put the graft using great auricular nerves or solar nerves.
Kavya,
Sir,
is there any contraindication for radiotherapy in this patient?
contraindication. Neural involvement is not absolute contraindication, sir. We can give radiotherapy.
See, I am speaking about this case particular.
If she has any collagen vascular disorder, sir.
See, there is no neural involvement. As you said, there is no facial nerve involvement. Yes or no?
Yes, sir.
Yes.
You have a big ulcer now.
Sir?
You have an ulcer. You said there's an ulcer.
Yes, sir.
There is an ulcer, which itself is a contraindication. If you give radiotherapy to the patient, the tumor may fungate wide open, and it is going to be troublesome for the patient with a lot of discharges and foul smelling discharges. So even for palliation, you cannot give radiotherapy in this patient. As Khanna sir said, even for palliation or whatever it is neoadjuvant, you can rely solely on chemotherapy. Depends on the response. We can plan our further surgical management.
Okay, sir.
Okay.
Kavya, do you have any doubts to be clarified? I think they have discussed most of the issues.
Is it a challenging case, sir?
Really challenging, sir. Both for the patient as well as the surgeon.
I think the sad part is we may not be able to offer much to the patient. That is it's a learning thing. Faculty, can we move to the next case now?
Sure.
Yeah.
Thank you, Dr. Kavya. Thank you for bringing up such a lot of findings and learning for this evening. Now we have, sorry, sir.
Srinivasan sir will definitely update on the post what is happening to the patient.
Wait for it updates.
Definitely, sir, because last case I have updated.
Yeah, that's.
This case I will find out, sir. The oncologist took over, sir. We'll find out. Next week I'll update, so what they're doing.
Yeah,
Yes.
Dr. Kavya, you have done it very well.
Thank you, sir.
Thank you, sir.
Now, with the permission of the faculty, we move to the next case. This case is a case of a gastric outlet obstruction, kindly contributed by Professor Vikram Kate sir. Dr. Likita Singh is a postgraduate resident from Tumour. Dr. Likita, try sharing your PowerPoint.
Yes, sir.
First,
Good
introduce
evening, sir.
yourself, your unit chief, your head of the department, and start your presentation.
Okay, sir.
Good luck to you.
Thank you, sir.
Yeah, we are fine, ma. Make it press
Yes.
F5.
Yes, sir. Is it coming full screen, sir?
No, I
Is
don't
it full
think so.
screen?
No, it is not full. Now it is full screen. Yes. Good luck.
Yes, sir.
Go ahead.
Firstly, I would like to thank everyone for giving me this opportunity to present at this platform. And my professor and unit chief is Dr. Kate, Dr. Vikram Kate, sir. And my HOD is Dr. Vishnu Prasad, sir. And I am a junior resident in the Department of General Surgery, Jawaharlal Institute of Postgraduate Medical Education and Research. And I'll be presenting a case of gastric outlet obstruction with epigastric mass today, sir.
So please keep
Shall I
going.
start?
Yeah,
Yes.
please keep going. Yep.
A 57-year-old gentleman, farmer by occupation, belonging to upper-lower class according to modified Kuppuswamy socio-economic scale, hailing from Krishnagiri district in Tamil Nadu, presented with complaints of abdominal pain for 3 months, vomiting for 2.5 months. The patient was asymptomatic until 3 months back when he started to have a generalized upper abdominal pain, which was insidious in onset, dull aching, continuous, aggravated after 1 hour of food intake, and relieved spontaneously after 1 to 2 hours or on vomiting. It was a non-radiating and non-migratory type of pain. It was associated with early satiety and postprandial fullness. He also had complaints of vomiting for 2.5 months, which was projectile, non-bilious, usually occurring in the night after 1 to 2 hours of dinner containing semi-digested food particles mixed with old food particles, having offensive odor and was not blood-stained. It was initially 1 episode per day, which gradually progressed to 2 episodes per day over the past 15 days. He had history of loss of appetite and significant unintentional loss of weight, that is approximately 10 kgs in the past 3 months. He also gave history of ball rolling movements. He has history of constipation for the past 2 months, passing hard stools once in 2 days. He had no history suggestive of jaundice, hematemesis, or melena. He had no history of heartburn. He had no history of chronic drug intake. He had no history suggestive of metastasis, which was swelling in neck or elsewhere in the body, or abdominal distension, bony pains, shortness of breath, or cough. Past history. He had no history of similar complaints of abdominal pain or vomiting in the past. He has no known comorbidities. He hasn't had any hospital admissions or surgeries in the past, and there was no significant family history. Personal history, he consumes mixed diet, which was high in salt and spicy food content. He has normal sleep pattern and bladder habits, but has reduced appetite and constipation. He doesn't consume alcohol, but is a smoker for past 20 years, which was amounting to 20 pack years with a smoking index of 400. He has no known drug allergies. Summarizing my history, it is a 57-year-old gentleman with complaints of continuous dull aching upper abdominal pain for 3 months, aggravated on food intake, and was associated with postprandial fullness, ball rolling movements, early satiety, and foul-smelling vomiting containing old food particles towards the end of the day, progressively increasing in frequency for the past 2.5 months, with significant history of intake of salty and spicy food, 20 pack years of smoking, progressive loss of appetite, and significant loss of weight, with no other systemic complaints suggestive of metastasis.
So what do you think
please
he's
go
suffering
back to
from?
your-
Yes, sir. Considering the age group, ma'am, he's an elderly male who presented mainly with complaints of abdominal pain and vomiting. I would think of some upper GI pathology, ma'am. And going by the complaints, I would think of gastric outlet obstruction, as he was having vomiting towards the end of the day, which was containing old food particles and had offensive odor. And he also had significant history of smoking and loss of weight and loss of appetite, early satiety. That with that, I would consider it to be a malignant gastric outlet obstruction now.
See, early satiety, and you're also saying he's having vomiting towards the end of the day. Now, what do you mean by satiety? How did you elicit the history?
Yes, ma'am. Early satiety is when the patient consumes less than the normal quantity, and still his hunger is satisfied. So I asked him if he was eating like normally before, but then he told that his appetite has reduced by half, and he was not feeling hungry even after that. He would feel he's satisfied with what he has eaten, ma'am.
See, that is where we always get confused. He's not eating because his appetite is decreased. Early satiety means he wants to eat, but he's unable to eat the usual quantity that he normally eats. So usually it is indicative of a space occupying lesion inside the stomach. Okay.
Yes,
And usually it is not, it doesn't go hand in hand with a gastric outlet obstruction. See, the outlet obstruction, usually the stomach will distend to some degree, not so much as in a benign cause. And he will be able to eat. Like you said, he may vomit towards the end of the day. So the satiety history should be asked very, very, in a very particular way, because here clearly he is loss of appetite, therefore he's not eating. So you cannot call it as early satiety. Okay, so early satiety usually indicates a body tumor, not an outlet obstruction, most of the times. So I think you should go back and look at the history. So don't put early satiety as a feature favoring gastric outlet obstruction. I would not agree with that. Thank you.
You are expecting a gastric outlet or gastric inlet here?
Sir, gastric outlet obstruction, sir.
But you said there is a food particle and the force smelling. That sometimes
Yes, sir.
if something goes inside the stomach, it will not be the food particle. Immediately it go for at least partial digested particle. And unless
Yes,
it
sir.
is very well, the end of the day, it will not be force smelling.
Yes, sir. Towards the end of the day, he already has some of the food which was which had remained from the morning meal, sir.
So
That
where is
along
that
with
food? Is
his
it going into the stomach or before the stomach itself it is coming out?
because he had old food particles which he had taken in the morning, sir. Even that was there in the vomiting. So I would consider that it was not immediately after the intake of food. The
No.
vomiting was.
The question is now whether you are having a undigested food particle or you are getting a partially digested food particle. If you say it's a food particle, that means it is the same food what he has taken morning murungakka, the same thing is coming in the night. That means it is
No,
an
sir,
inlet
it is.
obstruction. It could be a pouch or something. It is there.
Yes, sir. He had it was a semi-digested food particles mixed with old food particles, sir. It was a semi-digested, sir.
It must be because Madam has very well explained to you the early satiety. That is
Yes,
also
sir.
not fitting into this. And force smelling particle is also fitting into it. Is not going to the gastric outlet obstruction. What features you are thinking in terms of gastric outlet obstruction here?
So because vomiting, if it is a case of inlet obstruction, sir, the vomiting would be immediately after the food intake, unless there is a pouch which is there.
Remember, when will you get in vomiting in achalasia cardia?
Yes, sir.
Do you think it is immediately? It will take after around 1 day, 2 days, the same food can come.
Okay, sir.
So, but what made you to think it is a gastric outlet obstruction? And you are saying it is a non-radiating, non-migratory. What is the difference between these two? Non-radiating and non-migratory.
Sir, non-radiating is when the pain is starts from one place and radiates along from the site of origin to another site. That is called a radiating pain, sir.
The response to gastric outlet obstruction, you explained that. What condition of gastric outlet obstruction you are expecting a radiating pain and a migrating pain?
Radiating pain can usually occur in if he has a posterior apparatus involvement or pancreatic infiltration, then the pain can radiate to the back, sir. And migrate. Yes, sir.
What do you mean migratory?
Migratory pain is when the pain starts at one place and then it migrates to another place, moves to another place with no pain at the first site of origin, sir. So it is usually seen in appendicitis where it starts around the umbilicus and then moves. But in case of gastric outlet obstruction, I I am not sure, sir.
And what do you mean? You are asking something in the abdomen. What is the non-migratory, non-radiating? So with the relation to that, you are taking a diagnosis. Okay.
Okay, Litika.
Yes, sir.
Litika, am I audible?
Yes, sir.
Go to the next slide. That migratory slide. Yes. See, in case of benign, can this patient, benign gastric outlet obstruction, can this patient have a radiating pain?
Benign gastric outlet obstruction, sir. It is unlikely to have a radiating pain, sir.
Unlikely. You only
Yes,
said
sir.
earlier you said
See, in malignancy, can this patient have a radiating pain? If so, how?
Sir, in case of malignancy, when the carcinoma or it infiltrates the retroperitoneal structure or the posterior parietal structures, then the patient can have radiating pain, sir. But in case of benign obstruction, the pain will mostly be due to the distensibility of the stomach getting distended and causing the abdominal discomfort and pain, sir.
what is the definition of radiation?
Sorry.
Yeah, sir. Come please.
Sorry. Let me say, even in benign
Yes,
duodenal ulcer perforation. See, the perforation occurs in the anterior aspect of the stomach. If there is a erosion, that may lead to perforation in the anterior aspect of the stomach, whereas in the posterior aspect, it penetrates the capsule of the pancreas and it produces the pain. That is similar to malignancy. There is a possibility of radiating pain to the back, even in benign duodenal ulcer eroding towards the back. Okay. How will you find out the patient is having radiating pain and the pain radiating due to the involvement of the pancreas? On examination.
On examination.
Can you find out any change in posture of the patient? With which we can
Yes,
find
sir.
out the patient is having a radiating?
So patient would bend forward and
Yeah.
yes, sir. To relieve that will cause a decrease on pressure on the posterior parietus and then cause reduce in pain, sir. So he would be.
The patient stoops forward.
Yes, sir.
Yeah. Go ahead.
Okay.
Okay.
Next slide.
Likita, what are the causes of gastric outlet obstruction?
So gastric outlet obstruction can be due to benign causes or malignant causes, sir. It can be divided into intraluminal and luminal and extraluminal causes. So intraluminal causes could be because of bezoars, which are less common, but there can be trichobezoar or phytobezoar. And in case of other luminal causes, it can be due to gastric malignancy, which can progress to form gastric outlet obstruction. And otherwise, there can be duodenal ulcer, recurrent duodenal ulcer, which will cause stricture formation and cause gastric outlet obstructions. And other
Does the
extraluminal
duodenal ulcer causes the gastric outlet obstruction?
Sir, duodenal ulcer, when there is a recurrent duodenal ulcer, sir, it will heal by fibrosis, causing narrowing of the gastric outlets, sir. So it can cause the obstruction will be distal to the pyloric antrum, but then it will cause gastric outlet obstruction, sir.
And that means the first part of the duodenum, is it?
Yes, sir.
So
But the features would be similar.
exactly is not a gastric outlet. Okay, this is a duodenal obstruction, which is there, which is occurring in the first part of the duodenum there. Okay. Tell other causes for that. Yeah, tell other causes of gastric outlet obstruction.
Yes, sir. And
Dr. Khanna, one word I would like to say that just for the benefit of students, what you correctly pointed out, that Likita, what he was mentioning, the obstruction does not happen commonly at the level of pylorus. That is the reason we don't use classically the term as gastric outlet obstruction. So the term which was used in the past, nowadays this elective surgery and obstructions are very rare with peptic ulcer disease. So it was used as post-bulbar obstruction. Post-bulbar means you have the bulb of the first part of the duodenum, and the obstruction usually will happen at the terminal end of the bulb. That is why the correct term that was used was post-bulbar obstruction. This was just for the benefit of the students. Please carry on, Dr. Khan.
Yeah. Tell the other causes of.
Other causes, sir, could be if it is in younger age group or infants, it could be congenital hypertrophic pyloric stenosis.
Right.
And extraluminal causes could be due to mass effect. It could be by pseudocyst of pancreas, but it is extremely rare, sir. And then there can be due to some anomalies of the pancreas, such as annular pancreas, that can also cause an outlet obstruction.
Can
sir.
any inflammatory disease can cause the gastric outlet obstruction?
Inflammatory disease, sir. Yes, sir. Active ulcer disease in the stomach can cause edema of the pylorices, which could present as gastric outlet obstruction.
Can the tuberculosis cause it?
Tuberculosis causing due to gross enlargement of the lymph nodes in the abdomen. TB abdomen can also produce gastric outlet obstruction. sir.
No, it can be a
TB
mural or
mission.
it can be extramural. You know? Both
Yes, sir.
varieties are there. It can involve any part of the stomach, the duodenum, the proximal jejunum, which is there. Any part can be involved in that, you know, which may lead like a gastric outlet obstruction. And then another very important which you must ask is the history of some corrosive intake.
Yes, sir.
Mm.
Corrosive
Yeah.
acid ingestion can also cause stricture formation, sir.
Yeah, they
which can
exactly
lead to
cause the
gastric.
stricture at that area, at the pylorus. If
Yes, sir.
somebody has ingested the corrosive, they will present with a like the feature of the gastric obstruction because of the involvement of the pylorus.
Yes, sir.
Okay, right. Yeah. You go ahead.
Likita, two questions from my side. One is, you have written there, had no history suggestive of jaundice, hematemesis, melena in one sentence. I would
Yes,
have
sir.
preferred, where would I put this hematemesis and melena in this history of, where would I put? You know, your case is a obviously epigastric
Yes, sir.
mark. So where you would have put that? Along with the vomiting, probably you would have added, you understand, no? Patient
Yes, sir.
hematemesis. Patient has vomiting, all that you mentioned. You just add one word. Hematemesis suggests what kind of a pathology, probably in the stomach, if you consider carcinoma stomach.
Yes, sir. If you consider carcinoma stomach, hematemesis could suggest that it is an ulcerative lesion, which
Or
is
product.
causing.
Correct.
Yes, sir.
So obviously, other merit. Now, other question is that about this, you said about early satiety issue came. So, which is the classical, variety of pathological type, you get this kind of a feeling, no? Is I can't eat 3 chapatis, it's only half, little bit like that. Yes.
Sir.
Hmm.
So, early
Yes.
satiety is due to infiltration, sir, infiltration of the carcinoma into the deeper layers of the stomach, which could be beyond the submucosa, and then that causes loss of distensibility of the stomach, sir. Then it is that time when he cannot eat more, sir.
So earlier, we used to have that localized Lionitis plastica, earlier nomenclature. Now, we have the word diffuse. So that is one important thing you should realize here. Okay. So so what I would like to mention is hematemesis melena will go up. And this question of no history suggestive of jaundice, in particular to gastric outlet obstruction, why should you take the history of jaundice, you tell me?
Sir, it could be due to the nodal metastasis to the hepatoduodenal node, which could compress the port and cause jaundice, or it could be due to metastasis, sir, per se, to the liver. Multiple.
That will talk very advanced. No, very important message is there. Can something else can mimic like a gastric outlet obstruction? but it is not from carcinoma stomach.
Yes, sir. Gallstone causing gastric outlet obstruction.
Don't bring gallstone now. We are talking about this type of a situation, malignancy only. If you look at you mentioned pseudocyst and you said rare, but anything else can happen. With jaundice, see, correlate to jaundice.
Yes, sir. Yes, sir. It could be due to chronic calcific pancreatitis, which can cause fibrosis of the.
Why should it cause vomiting? Straight away, okay, so it's basically a head mass. You can have a head mass coming up and presenting as an outlet obstruction. Patient can present with vomiting, and jaundice is a clue for you. Obviously, it will be obstructive. That's all, sir, from my side.
Yes, sir.
One point I'd like to just add here.
Your history, you must, as Sarah said, asking the history. Suddenly you are asking about the heartburn, and you are talking about jaundice. Jaundice, you are talking in respect to the secondary effect. And heartburn, you are not talking about the secondaries of the disease. So the primary disease, you are going to talk about that. Similarly, the hematemesis melina. There must be some order which you are talking about symptoms per se to the disease. You are expecting a malignancy, then what is a primary or the secondary cause, secondary cause? If you put it in order, it will be a little better. And suddenly you are bringing the history of chronic drug intake. So there is no coherence of the case presentation. Any etiology you are going to talk, put it to the beginning. Then you have the symptoms you talk. Then about after the malignancy, what has happened. Then it will be good.
Okay, sir. And I'll keep that in mind when I take the next case, sir.
Sure.
I'll take it in order. Yes, sir.
Yeah, regarding just one point I would like to add regarding early satiety, we had a lot of discussion. Usually the description what Nikita has said, that is a common description given, that when it involves the wall of the stomach, intramural involvement, reduces distensibility. But we should also remember that one of the treatments for metabolic surgery is that you put a intraluminal structure or ball that reduces the luminal space. So what Dr. Ramya mentioned is also important, that if you have a proliferative type of growth and the growth is also infiltrating the wall of the stomach, then it becomes a complementary type of effect, and the patient can have early satiety due to both the components, that is intraluminal mass lesion as well as the wall which is involved, that reduces the distensibility. So both these things usually produce, ultimately the volume of the stomach comes down. So when the volume of the stomach comes down, the patient presents with early satiety. So just wanted to stress, because two consultants had mentioned, Dr. Shinoy had mentioned predominantly the wall, which is commonly described in book, but Dr. Ramya mentioned an important point, that if you have a very large proliferative region, that also can contribute to early satiety. Please go ahead, Nikita.
Yes, sir.
Yeah, please go ahead, change the slide.
Yes, sir. I'll start with my examination, sir. He was examined after taking verbal consent in a well-lit room in the presence of a male chaperone. And on general examination, he was alert, conscious, cooperative, and well-oriented to time, place, and person. His general condition was emaciated, but he was afebrile. He was normally built, undernourished, and dehydrated. His BMI was 19 kg per meter square, and ECOG status was 2. No pallor, icterus, cyanosis, clubbing, edema, generalized or supraclavicular lymphadenopathy. And his blood pressure was 116/70 and right arm in sitting position. And pulse rate was 96 beats per minute, regular rhythm, good volume measured in right radial artery. And respiratory rate was 16 breaths per minute. This is the examination of abdomen. I had examined after adequate exposure from nipple to pubic symphysis. Patient was examined in a supine position with arms by the side. And as the previous pictures had shown, on inspection, it was a scaphoid abdomen with fullness in epigastric and umbilical region, and flanks were free. Umbilicus is normal in position, centrally placed and inverted. Skin over the abdomen was normal. No nodules were present in the umbilicus. All quadrants moved proportionately with respiration. And visible gastric peristalsis was noted in upper abdomen from left to right. No cough impulse or swelling in the inguinal region was noted, and external genitalia appears to be normal. This is a video of epigastric peristalsis, which shows the gastric wave starting from the left side of the abdomen, moving towards the epigastric region and to the right hypochondriac region, and then diminishing slowly. Going to the palpation, abdomen was soft, non-tender. Fullness was palpable in left hypochondrium, epigastrium, which was extending into the right hypochondrium and was soft in consistency, probably a distended stomach. And 3 × 4 centimeter hard lump was palpable in the epigastrium, extending into the right hypochondrium with a nodular surface, well-defined upper and right lateral borders, and an ill-defined lower and medial border, with restricted mobility but moving with respiration, and the lump was not extending under the right subcostal margin. Liver and spleen were not palpable, and renal angle was normal, no lump or tenderness on palpation. Hernial orifices are free, and external genitalia was normal. Percussion, resonant in the right and left lumbar regions, hypogastric region, and right and left iliac fossa of the abdomen. It was dull in epigastrium, right hypochondrium, and umbilical regions. No pre-fluid or shifting dullness was noted, and the trough space was tympanic on percussion. Auscultation. On auscultation, succussion splash was present, bowel sounds were normal, and ausculto percussion revealed greater curvature of the distended stomach to be below the level of umbilicus. Digital rectal examination. There was normal anal tone, rectum was empty, and no mucosal irregularities, no pelvic deposits. Normal stool staining of the gloved fingertip was noted. Other systemic examination, cardiovascular and respiratory systems were normal. Summarizing my case history and examination, it was a 57-year-old gentleman with complaints of progressive projectile non-bilious vomiting containing semi-digested food particles with dull aching upper abdominal pain associated with postprandial fullness, early satiety, ball rolling movements, unintentional weight loss, and history of smoking. On examination, he had a normal build but was dehydrated and emaciated in appearance with BMI of 19 kg per meter square, ECOG of 2, and had an epigastric fullness with visible peristalsis with a hard lump palpable towards the right hypochondriac region of that fullness, which had well-defined upper and lateral borders and ill-defined lower and medial border. Succussion splash was present, and ausculto percussion revealed that greater curvature of the stomach extending beyond the umbilicus. With this background, I would like to keep my provisional diagnosis as malignancy of distal stomach with gastric outlet obstruction and no other clinical features suggestive of distant metastasis.
You said the BGP going from left to right, no?
Yes, sir.
Can you say that why it is going from left to right, and from then what happens to it?
Sir, visible gastric peristalsis is going from left to right because of the forceful contractions of the stomach against the obstructed pylorus. So a strong wave of contraction starts from proximal end of the stomach, that is the left part, and then progressing towards the right side of the stomach, sir.
Then what happens?
Then because it's obstructed, the gastric the wave diminishes, sir. The peristaltic wave continues, but the content is not able to move forward. So the distended stomach, which was there, would only produce visible gastric peristalsis from left to right till that extent, sir. But
You are
beyond
right,
that, we are not.
but I am asking the swelling you are seeing is not the wave, you are seeing the mass. That is the
Yes,
content
sir.
of the stomach. So what is happening
Yes.
to that? It reaches the not able to pass to the right, then
It will have
It's-
retropulsion, sir. So it will move
No.
back.
so it will, because there is already you will have a very dilated stomach, it slowly diffuse back into the stomach and the next wave starts.
Yes, sir.
Go back, please. Next. Next slide. Next slide. See, you have mentioned external genitalia appears to be normal. Yes?
Yes,
Am
sir.
I audible?
Yes, sir.
On inspection as well as in palpation.
Yes, sir.
You go to the palpation. You go to the palpation slide. Next slide. See, again, here also you said external genitalia is normal. What you are supposed to see in this external genitalia pertaining to this case?
Sir, I had taken that history for completion's sake, sir.
I'm really sorry. A postgraduate cannot take an history for the completion's sake at this point. That is external genitalia. You just think and answer. If not, let me explain.
Any testicular malignancies which were previously diagnosed?
You
And
should keep it in your mind. Whenever there is a lump in the epigastric region with a supraclavicular node or without a supraclavicular node, you must examine the testis to rule out a testicular tumor. Unless you examine the testis and specifically say the testis is normal, you are missing something. So with all this VGP and all, it might not be a testicular tumor. But make it as a habit to examine the testis whenever there is a lump in the epigastric region. Yes?
Yes, sir.
Don't say again, for the sake of completion, I have done this external genitalia normal. It is mandatory in male, if at all there is a lump in the epigastric region, it is mandatory to examine the testis. Understand?
Yes, sir.
Sir, one question. Sir. Nikita, just go back one slide.
Yes,
Yeah.
sir.
See, you have written fullness was palpable. Okay.
Yes, sir.
Is it that fullness was palpable or it is a wave of contraction that was palpable?
Sir, because the stomach was distended with gastric contents, so there was fullness which was visible. And on palpation of that fullness, it would easily give away, and the fullness would disappear under my fingers. So I would think that it was gastric contents which were getting displaced under my hand, which was palpable, sir. And on inspection, it was fullness which was visible. So I have kept it as fullness which was palpable, sir.
Somehow, on the safer side, it is better I used expert as a wave of contraction. It is just like any other mass, contracting mass. Sorry, there's some echo in this there. Classically, this is mentioned. Stomach, that is the seal, that is VGP. stomach that is felt, that is that contracting mass, and stomach that is heard. Okay, that's all. I think.
Nikita, what is the reason for the succussion splash?
Sir, succussion splash is because of the contents which are retained in the stomach and are not able to pass beyond the pylorus. So,
Do you have
Somebody
two
is
devices?
twofold.
Two devices without one. Anybody has got two devices or kind of devices without one?
shall I continue, ma'am?
Yeah, Likita, please continue.
Yes, please.
I think
Nikita,
Realme
you joined with
2 Pro.
two devices.
Realme 2 Pro.
1 second, sir.
Yeah, please mute that. Yeah.
Done, sir. Done.
Yeah, Likita, please. Yeah.
Yes, sir. Succussion splash, it can be present in normal individuals when it is immediately after the food intake. That is because of the partially filled stomach or partially distended stomach, sir. In case of gastric outlet obstruction, it occurs beyond the, it should be elicited after 4 hours of food intake, sir. So that we, if it is a normal individual, the gastric contents would pass beyond the pylorus by that time, and it would not lead to a false.
Why do you hear that splash?
That is the splashing of the gastric contents against the wall of the stomach, sir. Because it's
So
a hollow organ. Yes, sir.
If the stomach is completely full of fluid, will you get the
Yes, sir.
splash or not?
It is more prominent when it is partially half filled, sir, or partially filled. If it is completely full, the succussion, that splash might not be so prominent, sir.
Okay, for elicitation of the splash, there has to be at least two medium. The
Yes, sir.
liquid medium and the gas medium.
Yes, sir.
Until unless you have got these two medium together, you cannot elicit the splash. Like you cannot elicit the splash in a case of pleural effusion. But if there is a hydropneumothorax is there, then you can elicit the splash. Similarly, in the stomach, from where the gas comes, in the stomach from where the gas comes?
Sir, it's while from the oral cavity, sir, because oral esophagus, while we are taking food, it's not just the food, but along with that, we have some amount of
What is that called?
air or gas.
What is that phenomena called as?
I'm not sure, sir.
That's called aerophagy.
Yes, sir.
Okay. So 70 to 80% of the gas which is there in the stomach is because of the aerophagy. We always engulf the gas. And that is the reason in a case, if there's a dilated stomach is there, there's a liquid is there as well as a gas is there. You know, like it's in a pot which is there. If it is a pot full of water is there, you will not hear any sound if you shake that. But if half full is there, then you can hear only that sound. So that is the basic mechanism of hearing the succussion splash. Okay?
Yes, sir.
Right.
Yes, sir.
Litika, you have said there is a left hypochondrium. You are able to palpate mass. And
Yes,
can
sir.
you define what is the left hypochondrium?
Sir, the stomach is divided into 9
No, no.
regions
Okay.
based on
Yeah.
4 planes.
Tell me that.
Yes, sir. Yes, sir.
What is
Based on 4 planes. So the upper right, upper left region, which is between the left, the vertical line passes from the mid clavicular
line?
yes, sir. Left mid clavicular line, and the horizontal plane is the transpyloric plane, sir, in which
So how much area is there in the left hypochondrium for you to palpate mass?
Yes, sir. In this patient,
Second, you said trough space is resonant.
yes, sir.
So what is the boundary for trough space?
Yes, a trough space is a semilunar spacer, which is between when the mid clavicular line passes through the sixth at the tip of this sixth
Now,
costal
these
cartilage,
two
and
do
then
not, because these two do not coincide. I mean, go ahead with that, because it is very difficult for you to palpate a large mass in the left hypochondrium because it is a very narrow space there. Second, when you say trough space is resonant, you cannot have that mass if it is there. You will not have a resonant that swelling there.
yes, sir. It
No,
was
let me
fullness.
confusion here, Likita. Okay. See, Dr. Jailal, she's not mentioning about a mass. She's mentioning only about fullness. The mass is in the right hypochondrium, not left. That is why the trough space is resonant. The fullness is due to the distended stomach, which can lead to the resonance of trough space. So some confusion is there because then as fullness, it's fullness, not actually the mass. What you're interpreting probably as what you mentioned is rightly that if you have a large mass in the left hypochondriac region is extending beneath the hypochondrium, the trough space has to be dull. That's what you wanted to emphasize.
Yes, yes.
Some confusion because she has written it like that. So it's actually what she is telling is fullness due to the distended dilated stomach, which as very beautifully demonstrated and described by Dr. Khanna just now. Why do you get
yes.
flash? It has air there, which leads to the resonance of the trough space. Okay, I think we'll go for yeah. Likita, carry on. Okay.
Yes, sir.
So Likita, what is that mass you are feeling? What is your thinking about that? What is that mass?
Sir, I'm thinking it was a hard lump, which was palpable towards where at the point where the gastric peristalsis was stopping, or it was not visible beyond that. So I would think of some mass lesion which was present in the pylorus or antrum of the stomach, towards the distal end of the stomach, sir.
Okay. Anything else you can think with the similar findings which is there?
Yes, sir. It could be a pseudocyst of pancreas also,
No,
but
hard mass. Hard mass
The
in the
hard
same
mass.
area.
No.
Hard mass in the same area. Can it be lymph node mass?
Yeah, because you said restricted mobility only.
Yes, sir.
It's like moving with respiration, sir.
Right.
But the mass is moving with respiration, right?
No, partially or
Yes,
something
ma'am.
you have said that. Partially moving or something you have said. Okay. Restricted mobility, but moving with respiration. Okay, fine.
Yes, sir. Intrinsic mobility was restricted, sir. It was only mobile in the vertical plane to some extent, but in the horizontal plane, it was not
How will you
mobile, sir.
explain intrinsic mobility is restricted, but moving freely with respiration?
Sir, because it is an intraperitoneal lesion, it is moving with respiration.
Why
as
it is
the
moving with
stomach,
respiration? Why it is moving with respiration?
because of increase in the intrathoracic, it causes the shifting of intra-abdominal organs downwards, sir. So that is
So the
why
pressure
we
you are expected to intrinsically mobilize it is lesser than the pressure exerted by the intrathoracic pressure. No, it is. I don't understand when a swelling which is restricted mobility, even when you are holding it and moving it, but it is moving naturally with respiration. There should be also it is a restricted mobility.
Sir, this this swelling was not seen on inspection, sir. It was only palpable,
The
sir.
question is, if you have restricted intrinsic mobility, will it move freely with respiration? Both are contradictory. It's not possible. That's the question. Try to understand and answer. So maybe there is an error in one of the findings. Either it is moving well with on intrinsic mobility, or else it is not moving properly with respiration. One of the things only is correct. That was the question. So maybe there was some error in your finding. So maybe it is
Okay,
not
sir.
properly with respiration if you have reduced intrinsic mobility. So that must be the reason. Okay, we'll go forward.
Yes, sir.
Likita, what are the various ways to demonstrate the visible gastric peristalsis?
Yes, sir. Visible gastric peristalsis. In case of a patient who's taking orally, we could give them a glass of water, and after the intake of water, if there is because it causes distension of the stomach, the wave becomes more prominent, and it can be seen, sir. In case the patient is on Ryle's tube, and for decompression of the stomach, there can be we can do a saline load test, sir, in which we give around 500 to 750 ml of normal saline through the RT, and then clamp it.
That is for VGP.
I'm not
That is
asking
not for
for that.
VGP.
I'm asking for VGP. What are the various ways to demonstrate the VGP? One, you said that you will give a glass of water. Agreed.
Yes, sir.
And
What
from
else?
where you will watch, how will you do? That's all.
Yes, sir. Then I would ask the patient to lie in supine position, sir, and I would watch the peristaltic wave tangentially, sitting by the side of the patient, sir, with the eye, with my eye level at the towards the abdomen of the patient, sir.
Other ways, what are the other ways? You can
Other
demonstrate
ways?
the visible gastric peristalsis.
I'm not sure, sir.
You can just shake the abdomen of the patient. Okay, by shaking the abdomen of the patient, that can initiate the visible gastric peristalsis. Or some people even put like some sprit is there. You can put some spit over the abdomen, which you should not do. No, that is not good. But that is another way by which you can demonstrate that the visible gastric peristalsis. Now, if you have to demonstrate the visible gastric peristalsis, if you do a succussion splash, which one you will do first?
I would do the succussion splash first, sir. Though it comes in auscultation, but even I would first go to the auscultation, find if there is a succussion plus, then I would try to elicit visible gastric peristalsis if I had missed an inspection, sir.
Especially if you have to give the patient a glass of water.
Yes, sir.
Okay, right. Okay.
You go to your percussion,
Likita?
Sita.
Yes,
Likita,
ma'am.
one question. So it is a hypothetical question. See, there is a VGP present in a patient, but you are not able to make out the lump, whereas your chief is able to make out the lump. Where will you palpate and find out the lump? You understand my question?
Yes, sir. I would palpate where the visible gastric peristalsis is just fading away, and try to palpate by deep palpation method, sir, and so that to see if any lump is palpable in that region.
Yes, you are absolutely correct. Where the VGP ends, visible gastric peristalsis ends, that is the narrowest part. Most probably the lump may be there. Because of the experience, the chief or the senior assistants may be able to find out the small lump which could be palpable, where the residents could not be able to palpate. Okay.
Yes.
Regarding that, your percussion.
Yes, ma'am.
You have mentioned that it's resonant in right and left lumbar, hypogastric, whatever, but dull in epigastrium, right hypochondrium, and umbilical region.
Yes, ma'am. I think it's a that's error, ma'am. It should have been left hypochondriac region.
No, dullness is always, when you say percussion is dull, it is always over a solid organ. So
Yes,
what
ma'am.
solid organ did you palpate there?
It was
The mass
dull.
only you described, right?
Yes, ma'am. The mass was only in the epigastric region, ma'am, and in umbilical region it was partially filled stomach, which was distended and had led to the dull note on percussion, ma'am.
Basically, it's not dull. Just now, sir was telling very nicely about how it is partially filled with food particles, water, air. So what do you expect the note to be? What is the extreme is? One is totally resonant, another is dull. What is in between? It's called an impaired note.
Yes,
Yeah,
impaired
that is
note.
what is classically described over any stomach mass or a GOO where a stomach is palpable like this. Okay, so dull is always over a solid organ. Resonant is basically bowel loops with air and fluid in it, but here it will be impaired because of the tumor, the food particles, the water, the air, everything. So that is the one that you have to say. And what is the most important thing that you have not mentioned in your percussion? I don't know whether you mentioned whether I have missed it. Can you go to the next slide? Yeah, you have not mentioned it. What is the most important one? Because here you're talking about some vague mass palpable in the left hypochondrium, then there is a hard mass in the right hypochondrium. What is that you have to do in percussion? And here we are talking about a possible CA stomach, isn't it?
Yes, ma'am.
So which dullness is most important here? What about the liver span, the liver dullness? Have you mentioned anything about it? Why is it important?
Yes, ma'am. I should have mentioned about liver dullness.
Why is it
Liver
important?
dullness, in case of metastasis, there could be change in the liver span, ma'am. But on palpation, liver and spleen were not palpable.
No, but you felt a mass in the right
What
hypochondrium.
Madam is trying to emphasize, that's a part and parcel of examination. You have to mention that in percussion.
No, very important. Yes, sir. Thank you, sir. Very important is here is a mass, you're feeling hard mass in the right hypochondrium. How do I know that is liver or is it stomach infiltrating the liver? So where is a band of resonance? Where does the liver dullness end? And where does this note, impaired note or whatever on the mass, is there a band of resonance between the two? That means definitely it's not close to the liver. I know the liver is not palpable, but it has to be reconfirmed if possible on your percussion. And very important to measure the liver span in every case of abdomen. Okay. Thank you.
Yes.
Carry on. Move to the next, please. We are short of time now. It's close to 10.
Again, you have drawn out the stomach distension going below the umbilicus. So this kind of a distension is common in which kind of pathology?
When it goes beyond the umbilicus, ma'am, it is it means it could be a benign gastric outlet obstruction, or it is an malignancy which is confined only to the distal part of the stomach, ma'am.
Absolutely.
Because
you see a huge J-shaped stomach in a duodenal ulcer cicatrization, and the stomach mucosa and the wall, everything is normal. Or it is a very localized mass only in the pyloric, pre-pyloric region. Rest of the stomach, like sir said, did not have the infiltration into the muscle wall. Only in such cases would you get such a big distension of the stomach. Why should you know the degree of distension? How is it important for us as surgeons? One, it will give a clue as to the pathology. What is the most important?
If it is
say in the management of the patient, how does it matter to us?
Yes, ma'am. If it is a localized pathology only involving the distal part of the stomach, it indicates that it could be the tumor could be resectable and the patient can have a good prognosis. But in case if it is not distensible and the greater curvature is above the level of the umbilicus, it means the distensibility is completely lost, and it is a high-grade tumor infiltrating the entire stomach wall, which could be linitis plastica.
Okay,
Which will
that is
have
overgeneralization of the whole concept. What I'm saying is, in the immediate management of the patient, if the stomach is hugely distended. Now, I'm sure we are running short of time. What would be the investigation of choice for this patient to confirm your diagnosis of CA stomach?
I would do an upper GI endoscopy, ma'am.
Right. When would you like to do it in this patient?
After resuscitating the patient and taking baseline investigations and preparing him for endoscopy, because there could be gastric stasis, ma'am. So
Yeah,
I would
so the
first take
one thing is a hugely distended stomach. You may even take 2 to 3 days to decompress, remove all the dirt and muck before you do the endoscopy. For the same reason, when you operate on these patients, you have to wait for the stomach to really shrink a little bit, edema to settle down before you envisage any kind of anastomosis. So this gives a clue as to how much you have to prepare the patient before you really do anything definitive. And it also gives a clue as to what is a possible etiology of this distension. So it's very important. So this distendability of the stomach, marking it, some people consider it to be a very not so great test, since we have beautiful ultrasound and CT and all, but it gives a lot of information to the surgeon. I think it has its own importance. Thank you.
You said it is a foul smelling vomitus, no? Does it have any significance?
Yes, because it was old food particles which are not
Because
completely
this
digested.
stasis will produce more sepsis and the infection rate is more. Even when you are going to do a routine endoscopy, is there any role of prophylactic antibiotics?
For routine endoscopy, sir.
No, for this case, when you have a foul smelling vomiting.
Yes, sir. We can give antibiotics, sir, because we might be taking biopsies, and so that will cause.
Not for the biopsy, ma. You are going to do endoscopy. What else the patient can have immediately after the endoscopy, requiring antibiotic?
Biopsy will not require. Definitely will not.
Yeah, for biopsy, you don't require antibiotic.
I'm not sure, sir.
There's a chance of aspiration.
Aspiration.
Okay? Micro aspirations can occur. Patient may vomit, and that is why sir is asking about prophylactic antibiotic in this patient.
Yes, ma'am.
You move forward, please.
Okay. Yeah, forward. Proceed, please.
Okay, I think that no need for summary. This is your diagnosis. Investigations we have started now. Go forward.
Yeah.
Yes. So coming to the management, I would like to do baseline investigations and resuscitate the patient before going for confirmatory diagnosis.
You're told about endoscopy. Go forward. Biopsy also you're told. Now tell regarding the role of, we'll give you the findings. Upper GI scopy, you already have the findings there. Okay, that is what it is there.
Yes.
How will you interpret this endoscopic findings?
Endoscopy, it is indicating that there is a lesion which is obstructing the outlet of the stomach, which is in the antropyloric region, and it is circumferential, causing complete obstruction as the scope was not passed beyond the duodenum.
What is the significance of that? Scope is not able to be passed beyond.
It means that the growth is completely occluding the lumen, and
that is true. But what is the significance on the management of the patient?
On the management of patients, it indicates that patient would require a surgical management, as even endoscopically.
Even if the scope is passed, he needs a surgical management.
Yes, sir. But alternative options like placing an RT beyond the beyond.
Please understand, when the scope is not able to be passed, that indicates he is nutritionally unstable. He cannot have the routine. So you need to, the preparation of the patient takes a lot of time. So you need to monitor the patient fully, and even sometimes the nutritional supplementation is mandatory. But if the scope is passed, you are sure that is patient absorption of the vitamins and other things are there. So nutritionally, patient will be stable for the patient.
Yes, sir.
Even whether it is you are passed or not passing, the surgery is same. That is not going to be changed. But the management part and the preparation part is important for that. So what type of, in a gastric outlet obstruction, what type of electrolyte abnormality you are going to get?
Sir, in case of gastric outlet obstruction, it will be hypochloremic, hypokalemic, hyponatremic metabolic alkalosis with paradoxical aciduria in long-standing cases, sir.
Okay, good. So you have done that. Biopsy is also taken.
That's the report. Proceed.
Biopsy.
Case, sorry, 1 minute. In which case do you think this ABG and ECG, I mean, electrolyte changes will be more marked or pronounced? In which etiology of GOO?
And it will be more marked in
Benign or malignant?
cases, in benign cases, because they are slow growing, and it will take the
No, that's not the reason. What is the reason? It is more pronounced in benign causes. So what is the difference in the acid secretion between a benign etiology and malignancy?
in benign etiology, acid secretion is maintained, ma'am, in the rest of the stomach. But in case of
Yes.
malignant etiology, it can infiltrate the mucosal cells and could cause
No,
decreased
it is
acid secretion.
associated with achlorhydria or hypochlorhydria.
Yes, ma'am.
That is a classical thing in a malignancy. Therefore, your acid loss will not be so great in vomiting in a patient with a malignant GOO. Therefore, the abnormality of these alkalosis, everything will be less pronounced. That itself should give a clue. Patient may be dehydrated, but his ABG may not look so bad. So that also gives a clue. Maybe this is malignancy. In benign, it will be
Yes.
even more pronounced. You'll have to resuscitate with more electrolyte supplements, etc. Okay, that is ideal.
Yes, ma'am.
But this patient had melena, no? Melena and hematemesis was no. No
No,
melena.
sir. No melena or no hematemesis.
So biopsy has come as a diffuse type.
Yes, sir. Adenocarcinoma diffuse type, sir. And
What do you understand
going
by
to the
diffuse type?
diffuse type, indicates that it is not well differentiated. There are, based on Lawrence classification, it is divided into intestinal type, in which the morphology is maintained, and a diffuse type, which could be more high-grade tumors, and where the morphology is lost due to loss of E-cadherin, and can also be due to signet ring cells.
What is
Signet
the
ring
other name
morphology.
of the Lawrence classification?
Sir, Lawrence classification. I'm not sure, sir. Other name.
Or DIO.
It is otherwise
Diffuse,
called as
intestinal and otherwise, you know.
Okay,
So
sir.
this is other name for the DIO, the Lawrence classification.
Is it the expected finding or unexpected finding here? Diffuse type?
It is an unexpected finding, sir, because it is limited only to the distal part of the stomach. If it was a diffuse type, it should be more involving extensive.
Anthropyloric growths are usually intestinal type, is it not? So diffuse type you get more often
Or
in
in the fundus. And the
body and fundus. Proximal gastric carcinomas are diffuse type. Distal gastric carcinomas are intestinal type. Why that word is used, intestinal type?
Intestinal type, because there is metaplasia of gastric glands which look like intestinal, sir. So
what cell will be there?
Yeah, what cell?
it will be
It starts with G.
G. Goblet cells.
goblet cells, yes, sir. And
Again, it
yes,
types which secretes mucin, which secretes
yes,
xylomucin.
yes.
Types are also there. Complete metaplasia, partial metaplasia.
10. We'll stop in another 5 minutes, Dr. Kanagvel. Yeah. Go to the next slide, please.
Yes.
Hmm.
These are the CECT findings. On CECT, it showed an asymmetric circumferential heterogeneous enhancing wall thickening, noted in the antipyloric.
Interpret only. Everybody can read it.
Yes.
Interpret. No, how will
These
you...
are the CT. Yes.
Yeah, okay. Fine. Show the picture.
These are the CT images showing a distended stomach with wall thickening in the antropyloric region, sir. And as we can see here, there is doubtful loss of fat planes, which they have mentioned with the on the lower aspect. Next slide makes it more clear. This is the pancreas, where there is doubtful loss of fat planes near the head region of the pancreas, but towards the tail and body, there is a thin line which is seen. So there is maintained fat planes in the tail and body region of the pancreas. This is again same slide, a cut below, sir. Here the lumen is completely occluded, but here there is some amount of passage, but towards the end, again, it is completely occluded, sir.
Did they tell about the lymph nodes or not?
Sir, there were no prominent, there were only subcentimetric lymph nodes, which were not so significant, sir. Perigastric lymph nodes were seen, but they were not significantly enlarged to indicate a nodal metastasis, sir.
How many group of lymph nodes are there in relation to the CA stomach?
In relation to CA stomach, there are 16 groups of lymph node which are important, sir. And in case of patients undergoing gastrectomy and lymph node dissection, important ones are the first 12, first 12 lymph nodes. There are 1 and 2 lymph node stations 1 and 2 are near the cardia. Station 1 is towards
What is there in the D1, D2, D3?
So D1, D2, D3 is lymph node dissection from involving dissection of lymph node station 1 to 7, sir. And in D2 lymph node dissection, it is along with the D1 dissection, it is dissection along the common hepatic artery, that is station number 8, and along the celiac axis, station 9, and in the according to the recent guidelines, in along the splenic artery, that is station 11. And some Japanese trials have shown that lymph node dissection of station 10 could be omitted, which is the hilar lymph nodes, splenic near the splenic hilum.
So if
The
you
12B you
plan for a
include or not?
gastrectomy in this patient, what is your choice?
Yes, sir. In this patient, I would, because it is a confirmed case of malignancy on biopsy, I would like to do D2 subtotal gastrectomy in this patient, sir.
Will you remove the spleen or not?
Because there are, no, sir, I would not be removing the spleen because it is increased with there are trials which have shown that there is increased morbidity in post-splenectomy patient, and there is no there is no much difference in the disease-free survival of the patient despite a splenectomy or no splenectomy.
This is a diffuse type, no? Still you prefer a subtotal?
Yes, sir, because it is involving only for a length of 4.6 centimeter and a thickness of 1.6 centimeters. So there will be enough normal gastric, enough stomach which can where we can give a proximal margin for the stomach, sir. So I would prefer subtotal gastrectomy.
How much sure you will be doing that? The diffuse is only confined to this tissue, but not involving the upper tissue. Malignancy is not there in the upper part, because we know for sure that diffuse is more common or predominantly only in the fundus and body.
Yes, sir. In that case, to be sure of the margins, we can send an intra frozen section, sir, after doing subtotal gastrectomy. If the margins are free and there is no infiltration into the muscularis mucosa or there are no tumor cells, then
Is it multicentric or only focal? Diffuse type is a focal one or a multicentric one?
Diffuse type is usually multicentric, sir. But in this case, neither the even on CT there is no wall thickening, which could be seen in other parts of the stomach, and it can be supported with frozen section intraopsal if there is no infiltration into the other layers of the stomach and the margins where we have given proximal margin.
Okay.
So how you are going to reconstruct after the gastrectomy?
Yes, sir. I would like to do Roux-en-Y gastrojejunostomy after subtotal gastrectomy, sir, or Billroth to loop gastrojejunostomy could also be done, sir.
Which would you prefer?
Ma'am, I would prefer Roux-en-Y gastrojejunostomy because the afferent other complications after the surgery are less in Roux-en-Y gastrojejunostomy when compared to the Billroth 2 gastrojejunostomies.
So if
Yeah,
you
it is
do
the
the
most
roux and why in this
physiological
patient,
because it goes along the same route. It's the most physiological. Okay. Yeah.
if you do a roux and why in this patient, there is no stomach capacity is there. You are directly anastomosing the esophagus to the jejunum. So there's nothing like the stomach capacity. So can you make a stomach capacity, something like that? If you are going for the ruin why?
Likita, the question is if you have done a total gastrectomy and when you are doing a roux limb, not for subtotal, so can you make a capacity?
Any pouch or anything?
Yes, sir. There is we can make a Hunt Lawrence pouch, sir, where we leave a part of it is an end-to-side anastomosis, in which the part
It's like a J pouch, just
yes,
like
sir.
a J pouch. It's a Hunt Lawrence pouch which is there. So you get the extra capacity there, right?
Yes, sir.
So in this patient, if the margins are all negative, lymph nodes are negative, are you going to give any adjuvant treatment to this patient or not?
If margins are negative and lymph nodes are also negative with no lymphovascular invasion, sir, then adjuvant chemotherapy can be omitted.
But this is diffuse type, isn't it? Again, the same
A
question.
diffuse type.
Yeah.
Yes, sir. In this case, because it has a
It depends on the risk factors, is it not? So it is not only the margins or other points, other things also are important. The T stage is also important. If you have a palpable mass, what's the likely T stage in this patient?
it would be T4, sir, involving T3 to T4.
Any new adjuvant you
Sub-zero.
are going to give or straight away go to the surgery?
Sir, I would like to do staging laparoscopy before proceeding to the surgery, sir. And if on staging laparoscopy, the planes could be made out and there is no infiltration into the surrounding structures or no locoregional infiltration, then I would go ahead with surgery, sir. If there is a loss of, if the planes are not clear and there is locoregional infiltration, I would prefer to give neoadjuvant chemotherapy and then go ahead with surgery, sir, and as a second stage procedure.
Not go ahead with surgery, then assess the response
Yes.
and then consider surgery.
Reassess.
Yes, sir.
If
If
this tumor is
Likita.
not resectable,
not respond, will not do surgery, is it not? If the
Yes,
tumor
sir. Then-
grows on new
if the
adjuvant
tumor is
chemotherapy,
not resectable, what are the palliative options in this patient?
If the tumor is not resectable, sir, then I would like to do a palliative gastrojejunectomy. It would be retrocolic isoperistaltic loop gastrojejunectomy, sir.
Retrocolic?
And in
Palliative gastrojejunectomy, you prefer retrocolic. So you are going to anastomose the posterior wall.
never done. Okay, so let's never say that. I don't know why you said that. Nowadays, nobody does it for benign conditions also. So you should
Yeah.
not use that term. That was an outdated operation done 25 years back.
okay, sir.
Likita, am I audible?
Yes, sir. Yes, sir.
One more hypothetical question. The lesion is confined to the pylorus or distal portion of the stomach. How much clearance proximally you give, and distally how much clearance you give?
Sir, proximally, if it is more, if it is a T2 or more lesions, sir, then I would like to give a clearance of around 4 to 6 centimeter. If it is only a T1 or T2 lesion which is not infiltrating beyond, then 3 to 5 centimeter would be the I would like to keep the proximal margin as 3 to 5 centimeters.
Is
And
it on
distal,
T1, T2 basis or on the type basis?
sir,
Intestinal type
if
and
it,
diffuse type
yes, sir.
you are
If
going
it
to
is
say, or you are going
intestinal
to make
type,
it as a T1, T2 sizes?
sir, if it's a proliferative intestinal type, then it is 3 to 5 centimeters, sir. If it is a infiltrative ulcerative lesion, then I would like to give 4 to 6 centimeter margin, sir. And distal margin would be just beyond the, in case of total gastrectomy, just beyond the pyloric, in the first part of duodenum, sir.
So what is the advantage of Billroth 2 over Billroth 1?
Sir, Billroth's 2, Billroth's 1 is gastroduodenostomy. So there would be more of bile reflux and reflux esophagitis as well in that, sir. In case of Billroth's 2, it is the bile reflux is less when compared to Billroth's 1, sir. And otherwise,
Okay, I'll add upon 1 or 2 points. See,
yes, sir.
when you do a Billroth 1, you are maintaining the physiological continuity. With the compromise, see, your proximal clearance is well and good. You can establish. Whereas your distal clearance is always questionable. You may leave a microscopic disease on the distal side. If you do a Billroth 1, again, that may grow and obstruct again. Okay. Whereas when you do a Billroth 2, you don't go to that site. You are anastomoting with the stomach, remaining stomach. You don't near the stump where there is a possible microscopic residual disease. Number 1. That is one significant point in favor of Billroth 2. Apart from that, the blowout or leak is very high in Billroth 1, whereas which is significantly less when compared to Billroth 1, it is significantly less in Billroth 2. Am I right? Do you understand what
Yes,
I
sir.
have explained?
Yes, sir.
So,
What
Nikita, do
you
you have
have
that,
done?
only that palliation? You just told us that you are going to do a gastrostomy.
Yes,
That
sir.
is the only palliation which is there for this patient?
No, sir. If the tumor is infiltrating till mid-body or extending till the mid-body, and we cannot find a good dependent area for gastrojejunostomy, then I would like to do feeding jejunostomy, sir, and a venting gastrostomy because the patient is obstructed.
Can you do endoscopic gastrostomy?
Yes, endoscopic gastrojejunostomy, sir. Yes, sir, it can be done, sir.
Can you do endoscopic
But it
stenting?
requires,
Can you do
Ye-
endoscopic
yes.
stenting? Can you do endoscopic laser? So all are these various palliative options for this patient, is it?
Yes, sir.
What is Devine's operation? Have you heard about that? It was
No,
there
sir, I'm not.
40, 50 years back, but nowadays it is not practiced. But have you heard about that Devine's operation?
No, sir, I'm not sure of it, sir.
Devine's operation is that where you just cut the distal part and you suture that. And from the proximal part, you do a bypass. Okay, so the advantage of the Devine's operation was, the main problem with any malignancy is either it can get perforated, or it may bleed, or it may perforate, or it may fungate. Okay,
Yes,
so in that case, that portion will be away from the main food descent. Though no more it is done the Devine's operation, but it is like a distal closure of the stump of that and doing a proximal bypass here. Okay.
yes, sir.
I think we will stop here. Dr. Kanavagi has said that we should stop here beyond the
Right,
time.
sir, I think
So one question. See, you are doing Ru1Y. Yes?
Yes, sir.
Yes. So when you do GJ, what is the problem associated, or what is the advantage of Ru1Y over GJ? And how will you compensate, if at all?
Sir, I didn't get the question, sir.
Ramani madam has already answered.
See, you are doing a gastrojejunostomy. You have done a gastrojejunostomy. Yes.
Yes, sir.
So gastrojejunostomy, a patient with gastrojejunostomy after 15 or 20 years may develop a
Yes,
stump
sir.
carcinoma.
Yes, sir.
How can you prevent this?
Roux-en-Y gastrojejunostomy is more physiological, sir, which gives two channels, and the bile reflux would be less. And stump carcinoma incidence is less in Roux-en-Y gastrojejunostomy, but whereas in Billroth's 2 gastrojejunostomy, loop gastrojejunostomy, the length of their afferent limb is less when compared to Roux-en-Y. So there can be bile reflux, which will lead to achlorhydria and an acidic state, which can cause dysplasia of the gastric mucosa, leading to stump carcinoma. But that would happen after a period in over decades, around 2 to 3 decades. So it would take 20 to 25 years for that to develop. Sir. That would be a.
So in order to avoid this, you can do a JJ. Whenever do a loop gastrojejunostomy, you can do a
Yes, sir. That would be
jejunojejunostomy,
yes,
which
sir.
can bypass the bile.
Yes, sir. In
Which
case
can
of
bypass the bile. It is almost equal to Roux-en-Y anastomosis. Got it?
yes, sir. Bronze anastomosis in case of loop GJ, sir.
Sir, I think I need to stop here. Dr. Likita, do you have any doubts or any comments to clarify?
No, sir.
Okay, before we close, a quick comment about a couple of things I would like to share. One is, see, when you're talking about diffuse gastric cancer, the PG should be aware of the newer concept of next generation sequencing, right? So you have to definitely go back to the family tree, look out if somebody else is suffering from, or at least alert the progenies of this patient about a potential possibility of a hereditary transmission. And the most important mutation a postgraduate should be aware of is the CDH1. The next generation sequencing helps you to decide about what type of therapy this patient, and you get to prognosticate them. You may have done a fantastic total gastrectomy with the proper D2 dissection. Still, the patient may not do well because of the underlying genetic abnormality, what is existing in this patient. So prognostication, even in spite of doing a brilliant surgery, covering up with the possible adjuvant therapy, whatever is best possible, these patients, they definitely do not do well when compared to an infiltrated type of cancer, number one. Number two, now people are moving to especially the protein-based analysis. You should be aware of the protein-based classification of the tumors. People who are, liquid cytology is the one which is very useful in these patients. You have a set of markers which ROA gene, all those things you should be aware, because these are potential for your preparation for your multiple choice questions and recent advances. Apart from that, one other point would like to share is where people were talking about various reasons for obstruction. In corrosive obstruction, it is very typical. It is always, it spares the pylorus. It is in the antrum. There is always a normal mucosa which is between the pylorus and the antrum. That was the one which the professors were trying to identify or differentiate from the malignancy. So usually it is the antral stricture. I'm sure your department has done pioneering work from both Kate sir as well as Professor Ananthakrishnan sir, because the antral stricture of corrosive is a unique entity. And most of the times in corrosive strictures, we do not expect a visible gastric peristalsis. The only thing you may have a distended stomach is when you have double obstruction at the esophageal end and the antral end. These are the things you should be aware of. And the treatment policy for gastric antral structure is only an antrectomy and preferably a B1 reconstruction. All right. The B1 reconstruction, especially for these type of advanced cases, is generally avoided considering the bed recurrence. That is what is going to happen quickly. That's why we do not do a B1 recurrence, especially in these type of antral cancers. And the margins will be seriously compromised. And then the restoration also becomes challenging unless you are very experienced. You can do a stapled anastomosis, circular stapled anastomosis have all been reported, but they are all quite difficult to perform for a normal person. So ideally B1 is avoided. These are the couple of things I'd like to add. I think Ramya ma'am and other faculty would like to give any closing comments, ma'am. think Madam is
Very
not.
confident candidate.
Yes, sir.
No,
I was
no.
about to say
I
the
think
same
sir
thing.
has prepared her very well, but I think there is
Sir.
no limit for discussion on
She
GO.
has prepared herself. Okay.
That shows the amount of training you impart in your unit, sir. I think she's more than confident
Yeah.
for a MS level candidate for sure. Madam, your comments.
Okay,
Sir,
Yeah, the same thing I wanted to say.
Sir,
I
one
was
last-
quite impressed with her confidence. She's able to stand questions, try to think logically and get back. And that is what we want in a young surgeon. I think best wishes, and I really enjoyed the session. I thank all the co-examiners. And I think we had a very excellent discussion on this important topic. Thank you so much, sir. Kanagavil sir.
Madam, thank you for joining with
Thank
such
you
a
so
short
much, ma'am.
notice of few hours.
Sir,
Thank you very much. Karnakaran sir,
Sir,
you
one-
wanted to
one-
tell something.
one question. What is the single most important prognostic factor in cancer stomach?
Nodal involvement, sir.
No, sorry. It is serosal involvement.
Serosal.
It is serosal involvement. And that is the single most important prognostic factor. Thank you, sir.
Carcinoma stomach is 1, even T1, N1 is stage 1. So nodal involvement is not the very significant one.
Yes, sir.
So,
Thank you so much, sir.
thank you, senior examiners. Kate sir, thank you very much for staying with us for all 2 hours. And thank you for permitting your candidate to present here. Maybe after a month or so,
Yes.
I will again get back to you for another candidate to present with us. And Jalal sir, Kanna sir, Karnakaran sir, ma'am, and all the other seniors. I thank and wish both the past postgraduates well, Dr. Likita as well as Dr. Kavya, for your excellent contribution. Thank you very much. And we look forward for yet another session coming.
Thank you, sir. Good night. Thank you very much.
Good night.
Thank you,
night.
sir. Thank you, ma'am.
Thanks. Bye.
Bye.
Bye.